One thing is that I can only see Holly.
Come here, Carol.
Okay.
Let me
Maybe
scoot
we
you.
could do this too.
Yeah.
Okay.
We just need to level it slightly. I'll do that. I'll do it.
You two can be in there. Wow, you guys are great. That's good.
Okay, so I'm going to go ahead and get started then.
Okay.
So, I'm Dina, and I will give you my background. I've been a nurse for 16 years, always in adult health, and have been in education for the past 3 years here at Methodist. Altogether 5 years here at Methodist. So can I have you two each introduce yourself similarly?
Okay. My name's Holly Avery. I've been a nurse over 20 years now. Since 1996 is when I got my license, so a long time. And I have been in med-surg most of my career. I've been at Houston Methodist since 2007. I worked as a charge nurse in the med-surg units, and in 2018, I joined the Vascular Access Team, and so I've been doing that ever since, and I love it.
So I'm Carol Jennings. I have been at Methodist for 17 years. I started in ICU here. I've been an ICU nurse most of my nursing career. Before that, because I also graduated in 1996, I worked in veterinary medicine, and occasionally I still had a client that would pop up that would ask for the dog nurse. They're gone now. So I started, I've been, like I said, at ICU the entire time. I did do a stint as rapid response. I did do a stint in sepsis. And now, about 1.5 years ago, I was recruited to the Vascular Access Team, and that's where we are now.
Awesome, thank you. And then there's one more of you that's not with us today. Can you tell us a little about him so we can round off the department?
Well, I think most of you know Blaine Derrick. He has been a nurse for about 6 years now. Started as a PCA here at Methodist, and then he started working as a nurse on 7 West, I believe, and then quickly transitioned to the ICU and worked there for several years. And then in 2018, he and I actually trained at the same time for vascular access. So we've both been doing vascular access since 2018. And he is now pursuing his acute care nurse practitioner degree. So he's in school. That's what he's doing today. He's working on some homework. So that's why he couldn't be here with us. But
We really wanted him to be here because this would be perfect for him. So
yeah.
Okay. Well, I'm glad to have you too.
Thank you.
Is there anything else you'd like to share about the department in terms of how it functions, or?
Well, we're a department of 3. We work very closely together. We're, work very well together. We stay very, very busy. We audit all of the central lines in the hospital for appropriateness, and make sure dressings are changed and things like that. I'm sure you guys have received emails from us or texts.
or phone calls.
Yeah. But we insert all types of lines. We insert ultrasound guided IVs. We do midlines, PICC lines, and we're looking to advance our department to start doing arterial lines. So that's up and coming.
And we also are working on other projects like opening up a area down in outpatient so that we can actually serve the public for midlines and PICC lines. There's really poorly served in this particular area of Houston. And for midline, outpatient midline, you can't get an outpatient midline anywhere in this area. So hopefully in the next several months, actually short period of months, we're going to have a outpatient clinic opened up so that we will be expanding maybe our numbers at that time, maybe looking even to try and fill a void so that maybe we can get peripheral IV service a little faster than we're able to right now. We're just really not, that actually has to fall down to the bottom of our list at this time. So we got a lot of things that we're working on.
Okay. So speaking of all of those activities outside, the routine things that you do, you've been working with the education department in a variety of ways over the years. So wondering if you could just give us a little rundown of what you do in terms of educational activities.
Well, I feel like we're constantly educating. When we go to the floors and people have questions, can I give these two medications through a PICC line? When we find things like infiltrations or things like that on patients, we usually, sometimes we'll try to bring the nurse into the room and say, look at your IV. This is an infiltration. This really needs to come out. So we're constantly doing education on the floors, but we also participate in new employee orientation. We do a little presentation for all the new employees that start here with us. And things like this.
Yeah. Right. So this is the first of our monthly education endeavors. In the past, we really like to do quarterly education or annual education, but in an effort to make it more doable, we're going to take it in small chunks. And so you'll see this is the first of this style, and you'll see some more coming in January out of CP. So we did do a survey from the months of July to October, where we asked the staff to anonymously share their, to rate themselves in terms of comfort on a couple of different points. And then also gave them an opportunity to give us an open-ended response on what they'd like to learn from your team. And so I'm going to use that as some of the structure for today. Overall, there was 50 respondents, and there were respondents from really a wide variety of departments. If anybody is listening that wants to ask a question, I want you to know that you can also just let us know however it is you choose. You can put it in chat or just come off the mic if you have a question for them. We can accommodate that. So otherwise, I'll just keep going. So one of the biggest topics in the survey was on site selection, especially in the free text portion. There was almost all of the responses pertain to that. So I'm going to go ahead and I'm going to say we have maybe about 10 minutes to dedicate to site selection. So I'll just ask you as many questions as I can during that time. So the first one was, staff asked, in a patient with a lot of past history of IV access, so maybe exposure to harmful medications, maybe some scarring, so a lot of repeat usage. Well, first of all, what sort of changes or what changes happen to the vessels under those circumstances? And then what do they need to know about site selection for peripheral IVs when they're working with that patient?
Just to do a little bit of education right off the top of this, that's in and above what you just asked. This is why, as a group, we do not place just-in-case IVs. We get a lot of calls for, well, I want 2 IVs just in case, or the patient's not on IV medication, but we want an IV just in case. And, in the old days, we used to do that. We don't do that anymore because of this very reason, because venous access is a resource that can be used up. As a patient ages, as a patient has multiple sticks, as a patient has medications administered that are toxic or harmful to the vasculature, they can actually get to the point where we cannot get a peripheral IV in them. So as far as looking for access, if you come across a patient, I'm assuming this question is referring to ultrasound in this particular case, because I doubt that this person would be able to be accessed any other way. So when you approach a patient and are going to use ultrasound on him, there's a couple of places that we tend to look first, and it's going to be the front part of the arm here, and then right along the thumb line up here. There's brachial complexes on either side. There's a complex that just runs right along the middle in the cubital area. You can help me out here. You can.
Well, we prefer that when you're looking for an IV site, you choose a site that is away from an area of flexion, because when the patient moves or bends, that IV is going to do like what we call piston. It's going to move in and out. It can cause a mechanical phlebitis, and I'm sure you've all seen it when you have an IV that's in the antecubital and it starts leaking. Well, that's why, because it's in an area of flexion. Really, we prefer antecubital IVs only for short-term access, saying like if the patient needs a CAT scan and they have to have a large bore IV in the antecubital area, you could put one there for that reason, but it shouldn't be an IV that you keep or try to keep long-term, because it will fail. The best areas to start an IV would be the forearm, okay? If you have a patient with a lot of scarring, if you cannot find a suitable vessel to stick the patient, then don't stick them. Put in a consult for us to come evaluate the patient. Sometimes we look at a patient, and if they have, if we can't find a suitable vessel to use for a peripheral IV, we have other options that we can, ask the physician, hey, can we do this type of line, so that the patient isn't being stuck multiple times. So if you run across a patient like that, just, put in a consult for us. If it's at night and you run into this and you can't get a peripheral access on the patient, there are other alternatives. You can, speak to the physician and say, hey, vascular access doesn't get here until the morning. Can we give this antibiotic orally or IM until we can get an IV established in the morning? But please don't stick the patient multiple times if you already know that there aren't any good options.
Because the long and the short of it with ultrasound, what I was going to say is that if you are not practiced in the art of using the ultrasound, you're probably not going to get this person. You're probably not going to get a vessel on this person. So the best thing to do is, if you don't see something that you really feel comfortable with, please call us.
I've got a question for you guys outside. I just want to make sure that I'm also able to be heard. I'm kind of far from the microphone. I'm not sure. So next question, they had a question about rolling veins. So let's go back to basics maybe. What is a rolling vein? And do you have any tips for the average peripheral start?
Well, a rolling vein is something that you're not going to encounter with an ultrasound guided IV. Rolling vein is something that you'll see on a patient that has things that are poking out that you can see. And the reality is that what that is usually is that the vessel is kind of tough and it's just kind of hard to get through. So you're in there and you're bouncing off. The best way to manage that is to anchor it in one way or another. And everybody has to find a way that works for them. That's it. That's pretty much it. For the rolling vein, a lot of people say, oh, his veins are rolling. Well, it's just kind of a way of saying I couldn't get it. But there's only really one answer to that. You have to anchor the vessel and so that you can actually poke it and get through.
So pull the skin taut, so that the vein stays in one place. Basically what that means.
All right, here's another one. What does it mean when the vein flows? What's going on there?
Generally, that's when you go through the vein with the needle. You puncture through the vein and it flows.
It flows.
It flows.
Fluid is coming outside of the vessel into the tissues, and it's causing some swelling and probably bruising in the long run.
One of the things we get a lot of, we do a lot of education on is our IV catheters. A lot of nurses want to advance the IV catheter as soon as they get a blood return, but what you have to remember is the bevel of the needle may be in the vessel, but the actual catheter is a few millimeters behind the bevel of the needle. So you may have the bevel of the needle inside the vessel, but the catheter hasn't made it there yet. So you have to insert a little further to get the catheter inside the vein, and then you advance the catheter. We find that a lot of nurses, they're like, oh, that makes so much sense, so try that when you're starting an IV.
Just keep advancing. Yeah. Just a little bit more after you get that blood return.
Millimeters.
Yeah.
Okay. This one's kind of a big question. So staff in the survey, staff said on average across the board that they were less than comfortable with site selection for peripheral IV if they had to consider what kind of medication was going through that.
Okay.
So if that was the deciding factor, a little bit less than comfortable on picking the spot.
Well, you just have to remember the blood flow in the hand, in the wrist area is not going to be as fast as higher in the arm. So if you're giving vancomycin, a hand IV probably isn't your best option there because the medication has more time to sit there and irritate the vessel. So you probably want something a little higher up on the forearm.
I mean, peripherally speaking, you're going to be able to administer any of these medications if they're short term. But a medication like vancomycin is going to cause some phlebitis, which I know we're going to talk about a little bit later, because it is irritating to the vessel. The bigger issues are more, I think, when we get to vesicant medications, because these medications, although some of them are not appropriate, they're appropriate, some of them are not as, some of them are a little more irritating than others. They are appropriate for peripheral access, at least on a very short-term basis.
Okay, so what I'm hearing is that if the medication tends to be potentially more irritating, even if it's not yet a vesicant,
Higher up the arm you go, the better.
into bigger vessels, to dilute more. And also smaller catheter allows for greater blood flow around.
Yes. Yes.
Right. Next, we're going to continue kind of talking about peripheral IVs. I've got a couple more minutes of that. Just thinking that on the survey, staff said they feel really comfortable selecting the needle size for peripherals. They also said they feel comfortable with maintaining peripherals. So given that we have perhaps all that reason to take peripherals for granted, I wondered if you had any facts or information that might pop out as being new information or surprising information about peripherals.
Well, not new information or surprising information, but I mean, I'm hearing, oh, we know how to do that, and I think they do know how to, I think you do know how to do it, but some of you aren't doing it. When you walk in the morning to do your assessment, one of the first things you need to look at is that IV. And you need to check out, is that IV intact? Is that IV infiltrated? Because we've heard it more than once. Well, I haven't had a chance to look at that yet today, and it's 11 o'clock, so, a fourth of your day is gone and you haven't assessed your IV sites yet. So I think 99% of maintaining an IV is going to be laying your eyes on it, and maybe your fingers on it too, and just, taking proper intervention when you see that it needs to be done. And it's as simple as that.
May I ask you just if you would, to touch on the no routine changes of IVs?
Yes, that's a standard from INS to not change an IV site unless it's clinically indicated, which is best practice, because we want to preserve those veins, because we can use them up, like Carol talked about earlier. We want to keep those IVs, as long as we can, as long as they're healthy, which goes along with what Carol was saying. You need to lay your eyes on it. You need to touch it. You need to ask the patient, is this, when you're flushing it, is this painful? Because really, if a patient's complaining of pain at an IV site, it needs to come out. There should be no reason that it hurts. What are you gonna say?
I was just going to say that's another point to bring up is if it's not good, don't leave it there.
Right.
If the IV is bad, don't say, well, if I take it out, they won't have an IV, because they still don't have an IV. Take it out. If it's bad, take it out. If it hurts, take it out. If it doesn't look right, take it out.
We do work someplace that has a lot of resources.
Yes.
And if it's ever been my hesitation to take out an IV, it was because my main fear was, how am I going to get another one in?
And I think that's what a lot of it is.
But I also never worked someplace that had the large numbers of ultrasound guided trained staff. So we're grateful for it.
Mm-hmm.
As are we. Yes.
Well, those cover my peripheral questions so far. So I'm going to move into central lines. Yeah. So here, staff said that there was a big, the only real discrepancy that I could kind of see with maybe an unaddressed need, a strong unaddressed need, was staff rated their comfort in the knowledge of the difference between the types of central lines as being kind of not quite comfortable, still in that, ooh, I'm kind of neutral. So I'd like to give you the floor to talk about the different types of central lines.
Did we want to try to move the camera in, Will?
I think so, yeah.
Okay. You want to take this?
Okay, well, so we have our little model here.
If you will, just trace with your fingers, because I see that the lines themselves are not as evident. So when it comes time to start and stop.
So we have here a PICC line. This is a line that we insert. PICC line stands for peripherally inserted central catheter. We've had nurses tell us before that a PICC line wasn't a real central line. Well, it is. If you can see here, it goes from the peripheral arm here in one of the big vessels of the upper arm, and it goes all the way into the superior vena cava above the heart here, which is the same vein that this subclavian line ends up in. So this is a triple lumen central line, and it's a subclavian, and the tip of it is in the exact same location as the PICC line in the superior vena cava. A lot of times too, you'll see like an internal jugular line, which the insertion is up here on the neck, but the tip of it is still in that superior vena cava, okay? So the tip of your central line should always end up in the superior vena cava. This is a femoral line, so it's inserted in the femoral vein, and it would go up this way, okay?
Supposed to, it's just kind of hanging
Yeah,
up to the side there.
this one isn't really cooperating with us, but yeah, it should go up like this. And then here we have a midline. And the tip of the midline just ends up here right in the axilla. Okay, so a midline is not a central line, it's basically a long peripheral IV. There are also tunneled lines. Those are placed usually by a physician. You'll see tunneled central lines and also tunneled dialysis catheters.
How is the tunneled line different from your subclavian over there?
Well, it's tunneled under the skin before it enters into the vein.
Sometimes there's a balloon that's blown up to just keep it anchored in place. And these types of lines are used like PICC lines for long-term medications at home often.
Thank you.
You got to do too.
All right, from those at home, we're logging in from outside this room. Please let us know if you have any questions. We can take them. Feel free to come off your mute. So about midlines, we just reaffirmed that they're not central lines, but closer to a long peripheral.
Yes.
Why do we choose to use those? Who places them? How long can they stay in?
Okay. We are the only ones in this hospital that place midlines currently. They are meant for patients that need a week to a month, basically, of therapy. Any line, though, falls under the same criteria as a peripheral IV, which is you can leave it until it's clinically no longer healthy. Okay. The IFUs, or the instructions for use, say only 29 days, but it can stay longer as long as it's healthy and there are no signs of complications. What was the other question?
Who places them? You do, how long they can stay in? Okay, I have more questions. What medications do we infuse with them?
Typically, they're used for IV antibiotics. Now, we don't like to place midlines for vancomycin. We also don't like to place midlines for peripheral nutrition. The reason for that is the tip of the midline is sitting in a very deep vein, and the tip of it is in the axilla. You won't be able to see when damage is happening until it's too late. That's why, vancomycin short term is better in a peripheral forearm vessel and also PPN. If the patient's going to need longer term nutrition or vancomycin, we usually recommend to the physician to place a PICC line because the blood flow there is, so great and it dilutes those things right away. Anything to add?
No, that's pretty much it.
So that led to my next question, which was, what would be the biggest takeaway for the bedside nurse in the maintenance of a midline? And I feel like I have my suspicion that it has to do with infiltration.
Well, I mean, obviously you need to keep an eye on the surface like you would with any other vessel, but with a midline, in addition, when we put in a line, we will take a perimeter reading in centimeters, and we will put it on the wall. We have a bright orange sign that we put on the wall that says arm circumference is this many centimeters. You should actually be checking that at least a couple of times a day.
It's every 8 hours.
We like to say 3 times a day.
Yeah.
But I'd be happy with a couple of times a day. Just because if you have a couple of centimeters difference, I mean, that's no big deal. People can measure different parts of the arm. But if you have, 5, 6, 7 centimeters more, then perhaps you're looking at an infiltration, and you can catch it earlier than you would have, if, before it starts to, have other bigger problems. So that is a big part of maintenance for midline, is watching the circumference. And then just in one more part of that question, and I don't know if it got answered or not, is why would we place a midline rather than a peripheral IV? Yes, for long-term antibiotics, but on occasion, with some of these folks that we cannot get a peripheral IV in, and there are more and more and more of them that we're getting. Sometimes that's the only vessel that we can access, and it's not an appropriate vessel to put a peripheral IV in for many, many reasons. We go into them, and I don't think people quite grasp what we're saying, but if you put a peripheral catheter into one of these vessels that we use for midlines, also for PICC lines, as soon as the patient bends their arm, it's going to pop out of the blood vessel. It's not going to be in there anymore. So it may look great when you get it in there, and usually they're nice vessels because nobody picks on them because they're deeper. It's going to look great when you get it in there, but as soon as the patient does this, it's not going to look great anymore, but you're not going to be looking at it anymore. So it's infiltrated. The best thing to do, like I said, is monitor the circumference. And if the patient cannot be given an IV peripherally, let us come and put in that midline.
Thank you. Can we move then into the rest of a broader discussion about complications?
Sure.
And so I'm just going to start with the most basic that I think of is phlebitis. And you mentioned mechanical phlebitis earlier, even with that word pistoning, which I like. I'm going to start using that to describe that action of what happens with flexion. So mechanical phlebitis is one kind. What other types of phlebitis are there?
Chemical phlebitis from the medication, yeah. And
Go ahead.
And there's a third kind.
I think I saw a couple, but infectious also.
Yeah, that's what, infectious phlebitis.
So from poor technique, I would assume, yeah.
For technique, for maintenance.
So if your patient has a hard, palpable, red cord on their vein, that's phlebitis.
It hurts.
Yes, please don't leave that IV there. Please take it out.
It's only asking for more trouble,
yes.
Right?
As soon as you notice that, please take the IV out. I mean, we've come across patients with some phlebitis that the IV is still there and it's still infusing, and so we usually go in and take it out.
Okay.
But yeah, that's just damage to that vessel and pain for the patient.
It's generally just damage to the innermost layer of the blood vessel, but it causes that hard, painful cording. Any of you who have ever experienced it know what we're talking about. And yeah, the best way to get to resolve that is to just remove the irritant.
Okay, thank you. So then moving into infiltration and extravasation, I saw something interesting on the survey. I found that out of the 50 respondents, 36 of them said they were very comfortable with the difference between infiltration and extravasation. And which is, I feel like that's, even though it's totally anecdotal, a couple years ago having conversations with people about the same subject, and there was a knowledge gap for sure. So I'm just interested to hear from you if you feel like that was just a poll of 50, but do you feel like that would be representative of the current knowledge among staff, or do you think that there is a bigger gap than that?
I think there's a gap still. I mean, when we were going around doing the game, the Wheel of Venous Access.
Oh.
By the way, this is Vascular like Comic-Con, Vasicon.
We found that people did not, in fact, know the difference between infiltration and extravasation. So
I'm curious to know, you asked them if they felt comfortable. Did you actually ask them to define it for you?
No.
They may be comfortable in their misknowledge. They may not know what they don't know.
It was even a dual question. It was comfortable in the knowledge and the difference between the two, as well as the treatment management of. So we have maybe about 10 minutes, if we can, to talk about this. If if, as you suspect, there is a bigger knowledge gap, then can we talk, starting with defining infiltration versus extravasation?
Can we,
Where's our
Once
poster?
again,
the infiltration?
I have it here. It's just-
Maybe I could just bring this poster up to here. And,
Can we put it right up here?
well, I was thinking if I,
It's upside down.
if I hold it and you shine the camera on it and then Holly describes it. Well, or you can hold it. Okay, that's fine.
Okay.
She's gonna hold it. We're gonna take it.
I'll hold.
Oh, sorry.
All right. I think it might be better on the table.
Yeah. Okay, well,
Okay. And then.
okay, so phlebitis, we said, an irritant that causes damage to the tunima intima of the blood vessel. And it causes a palpable cording. It's not always going to be red like this. Sometimes you just feel that. And again, we just discussed this with phlebitis. The best thing that you can do is just to remove the irritant. And it usually will get better within a period of time. I personally had an experience with phlebitis with a one-time antibiotic. It was Rocephin. It was a pre-surgical thing, and I had it for a good 2 weeks. It lasts a long time. Okay, so infiltration. Infiltration is going to happen. We're here? Okay, we're good. Infiltration is going to happen when the fluid that you are infusing actually leaches out of the vessel and into the tissues. And with something like normal saline, you're going to experience maybe some swelling, but over a period of time, there might be even be a little tissue damage, but for the most part, it's probably going to be just fine. But anything else, anything chemical, is probably going to cause some type of a reaction as you're seeing in here. With as you move on down, with extravasation, once you have entered into the vesicant medications, you're going to start experiencing severe tissue damage. And you're going to have ulceration, which is a classic sign of actual extravasation. You're going to actually see some tissue damage. Can actually bleed from this to this. So treatment, for phlebitis, remove the irritant. For infiltration, turn off the fluids, and depending on what it is, you may want to apply heat, you may want to apply cold. Check with the pharmacy; they're gonna help you out with that one. For extravasation, once you've gotten to this point, you are going to require probably extra physician care, and at some point, you're probably going to have some wound care and maybe some antibiotics to treat that as well. That's a pretty serious thing. People can actually lose limbs from that.
And there is we have a policy on the medications that can be used for certain drugs that are infiltrated to use, and pharmacy is a good resource for that. And you can also pull the policy to tell you exactly what to do.
Got a couple policies identified here.
Yeah, management of peripheral IV infiltration, management of extravasation of non-cytotoxic agents, and extravasation of cytotoxic agents. So those are all present on the intranet. And like I said, again, pharmacy is an awesome resource. They can really help you with that too. So
One of the things that I got from reading both the policies as well as some of the articles was that you really cannot make any broad assumptions about how to address the extravasation. Sometimes you need to even retain that IV in order to administer an antidote.
right.
So you can't even assume I need to quickly take this out. You have
Right.
to stop the infusion
Stop the infusion, but leave the IV in place. That's a very
until
good
you
point.
determine that.
Until you know what you're treating, until you know what to do.
Very good point.
Not to apply any type of compresses without an order.
Right.
And pharmacy is a good resource, as you said. And then documentation. So for the patient, for that record to be accurate, we need to do some post-event documentation especially on an extravasation, all of them.
Mhm.
Yes.
So kind of accurately documenting objectively what is seen and what actions were taken.
Yes. Yes.
And I think that the best way to do that is just a narrative.
Okay. And I think all of the required points would be found in the policy. Okay. All right. So we have a couple more minutes. If we have time to talk about other types of complications. Sure. And one I thought was important was the occlusion of catheters. Can we talk about cath flow?
So cath flow is actually TPA, administered in a very small dose to a catheter such as a CVC or a PICC line that has been clogged because most of the time probably hasn't been maintained properly.
There may be like a little fibrin tail on the end of it that allows you to instill medications, but when you draw back, the fibrin covers the end of the PICC line and won't let you draw blood. Those issues like that need to be taken care of right away.
That is, I don't want to let that point go by. If you have a PICC line or a central line and it does not draw back blood, that needs to be addressed.
Yes.
Not just that you can push fluid into it. You need to be able to draw back blood. If it's a central line, it should always draw back blood. If it does not, you need to call us and we will tell you how to fix it, or we will come fix it ourselves.
Cath flow, if you've never given it before, it's pretty easy to do, but if you've never done it before, it's a good idea to get your charge nurse or someone that's familiar with it to go with you. When you open the box of cath flow, there's a big insert in there and it tells you step by step exactly what you're supposed to do. It also tells you on the EMR, when cath flow is ordered, it tells you how to administer it. But if you've never done it before and you're uncomfortable, get your charge nurse or call us. We can come help.
Yeah. Thank you. All right. With the last couple of minutes, we had some questions about the tools that get used. So oftentimes I read in the free text thing just simply the words ultrasound guided. And so although I'm not positive, I am guessing people are just interested in ultrasound guided, like what it is, and perhaps they're asking also about how to get involved with it.
Okay. Ultrasound guided IVs are, it's not an easy skill to learn how to do. It takes a lot of time. As Carol can attest, when she joined our team, she had no experience with ultrasound. So it took a good 6 months.
Took a good 6 months. I've had people, we do classes once a quarter and generally try to hit charge nurses and people that we know can be, can check off other people. If we could ever get that group of people together, then we could move on and do more classes. The thing is that once you have taken that class, it is up to you to get out there and start the IVs. You've got to get out there and practice, because if you do not, you will not get this skill down. It took me 6 months.
And that's doing it every day, because that's all we do. We use the ultrasound for every line that we insert. Most times, it's rare that we'll do an anatomical stick for an IV, but it does happen. But most times we use the ultrasound for everything. So, and Some people, it takes a good year before they're comfortable using the ultrasound to start IVs. It is not an easy skill. And it's really best if you have a good base of knowledge with starting anatomical IVs before learning how to do ultrasound. It's not going to make it easier for you to start IVs. Believe me, it takes a lot of hand-eye coordination. It's you're not looking at the patient's arm like when you do an anatomical stick. You're looking at the arm. With this, you're holding a probe and looking at a screen. It's not easy. I don't know how many times I can say that, but it takes a lot of practice to learn it.
But I will also say this. I have the worst eye-hand coordination of any person on the planet. And I'm actually pretty good with this, so anybody can learn how to do it.
Yes, that's
But
true.
you do have to practice.
Dedication.
Mhm.
Yeah, written into it. Can you talk to us about, Bertha?
Bertha?
Yeah.
You mean
Who
the
is
fourth,
Bertha?
the fourth person of our team? Bertha is an ultrasound and suitcase, essentially, all in one. Bertha is our cart that we got that we have mounted our ultrasound machine on. Actually, it was Blaine's baby.
Yeah.
He kind of had the inspiration for the whole design, and then we had some help with
From Biomed.
from Biomed.
Yes.
They put it together for us, and then of course Bertha was born when I decorated her, so she does like to express her opinions. Each holiday she will change her appearance, and we've tried to get a little more flamboyant with her, but with infection control on patrol, we had to kind of scale it back a little bit.
I'm just checking to see if I have a picture of her actually.
Well, that's
That's the back of
Bertha.
Bertha.
That's Bertha, displaying the wheel of vascular access. She decorates for all of the holidays, though. You have to see her from the front.
Oh, no, I'm afraid not. No really good pictures of her.
Mm-mm.
But while it's up there, we can share the spinning wheel anyway.
We do kind of like to make her have a personality, though. Primarily, we didn't even think about this, I think, ahead of time, but when you're walking into a patient's room, one thing we generally ask is that, if you have consulted us, please let the patient know that we're coming, but sometimes people don't. And when we walk in with that great big machine, people get very intimidated. And I just think, making it a little lighter.
Yeah, we say, oh, that's just Bertha.
Yeah.
She's no big deal. She's just a big suitcase, really.
Okay.
So,
And right now she has still on her, maybe mounted, still has the wheel mounted?
No, we took it off.
The wheel is off.
yeah.
Wheel is off.
But
Okay.
but it can be put back on at a moment's notice.
I'm really interested to hear about that game that we played last week. So,
The wheel of vascular access.
yes.
It was a lot of fun. People enjoyed it.
I did the voice. How come you can't do the voice?
Oh, you do the voice better.
Well, you never even tried to do the voice.
The wheel of vascular access.
Sorry.
So that was one of the three big events planned for this month of education. First, we did posters, and the posters were put up near the cafeteria, and still have hopes to get them distributed out to the units and rotated through.
Yeah.
That's what we're seeing, 2 of the 4 behind us. Then the second week was the game.
Yes.
And your team came up with those questions, and there was a number of questions available.
Yes.
And you rounded on staff during your normal activities.
Yes.
And then one of the staff nurses came out with me and rounded on night shift.
Mhm.
So popular.
I think it was
We had a
very
great time.
it was very popular. People enjoyed it. It didn't take a long time. They could just come, answer a question, get a prize. And I think people learned a lot, actually.
Mhm.
Yes.
They're like, oh, I didn't know that. I learned something. And we even had some physicians
Yep.
answer some questions, and they didn't know the answers.
Mhm.
We had one physician, Dr. Sharma. She was like, oh, well, I don't really want the prizes, but just
Give me another question.
tell me more. I want to learn more. So,
Awesome.
you know, it was good.
Right, so I want to thank Jim Alonso
Yes,
as one of
thank
the
you.
staff nurses who came out to help participate with it. And then also want to thank marketing because they gave us some really good prizes to get started with. And then of course, the candy and the salty snacks too were
Yes, thank you very much.
appreciated. Thank you, Carol, for donating yours.
You know, it is around Halloween.
I think then just kind of closing out, I'm interested to hear about like what you think of your profession that you're in currently. And then I'm interested to hear what is the future state of vascular access, not necessarily just here at Willowbrook, but where is vascular access going as a field?
Well, it's an up and coming field. I mean, IV access touches every patient that comes into the hospital, and it's important. Like we said earlier, veins are a limited resource, and we need to take care of them and preserve them as best we can. You know, there's so much new research coming out with vascular access, so many new products. I mean, there's so many things that we'd like to do as a team.
Yeah. There's actually, I mean, potential for us to, at some point, and I'm not going to say that this is going to happen anytime soon, but there's a potential somewhere down the road that a vascular access team could take care of every IV need of the hospital, a much larger vascular access team.
Yes, the three of us can't do it.
Starting all peripheral IVs using sterile technique, putting in central lines, putting in arterial lines. Yeah. There is actually the potential down the road for that to be a nurse-driven thing. So there's places to go. And as far as how do we feel about it, we love it.
Yes. Yeah, we love our job. We wish we could do more, but it's hard some days because we're, so busy getting so many orders, and sometimes it's hard for us to get to everything. Some things we have to put off to the next day, and we always hate doing that, but hopefully in the future, our team will grow and get some more staff so that we can provide more services for the hospital. Because, like I said, IVs touch every single patient that comes into this hospital. And it's important.
All right, well, I can't tell you how grateful I am for your participation this whole entire month and in the months that led up to this in planning.
Months.
Yeah.
It's a Dana.
Yes.
It's my pleasure. My pleasure.
Yes, thank you guys.
So
Amazing.
we will close out. Please look for the posters to be in your nursing units. I would like to share with you that we have a new model. Just behind Carol there, we just got in a couple of new
Gravy.
vascular access arms.
He's heavy.
For doing trainings like phlebotomies and IV starts. This guy and one more came in yesterday, and they're some of the best on the market. We're excited to
Yay!
He's very veiny. He does feel like he has some phlebitis.
He does have right there.
Yeah.
Okay. Okay. Thank you everybody for tuning in. Can't wait to share this with all of you.
Thank you.
Bye.
Bye.
Thank you.